Right now, across the country, roughly 50% of psychiatric patients who develop a highly distressing, potentially life-threatening medication side effect are being actively misdiagnosed by their
Yeah,
providers.
it's a staggering number.
Mm,
And the terrifying part is the standard clinical reflex to, fix this misdiagnosed problem is to double the dose of the exact drug causing the issue in the first place.
exactly. And that specific misread is costing careers. And much more importantly, it's costing lives.
Right, because when clinicians mistakenly push the dose of the offending drug in these cases, they're actively worsening a condition that drives people to the absolute brink.
I mean, we are talking about an independent, direct link to suicidality, severe treatment dropout, and even violence towards self and
It's
others.
that serious, it really is.
So, whether you are a brand new PMHNP prepping for your next clinical rotation or a seasoned practitioner catching up on the latest guidelines, this deep dive is custom tailored for you.
Absolutely. Because today, our mission is to completely dissect the Akathisia Management 2026 PMHNP decision tree.
We're going to explore the mechanics of why this side effect masquerades as something else, how to objectively trap it using the BARS tool, and the definitive 2026 pharmacological algorithm for putting an end to it.
To really solve the problem, we first have to pull back the curtain on the clinical illusion itself. I mean, we have to
Go
understand why half of these cases are totally misread.
Right. So let's define it. What are we actually looking at?
So akathisia is treatment emergent, meaning we cause it with our prescriptions, specifically dopamine blockers. And it presents with two core components.
Okay, what's the first one?
First, there's a subjective sense of profound inner restlessness. Patients will literally tell you they feel like they're crawling out of their skin.
Oh, wow. Yeah, like this overwhelming, irresistible urge to move.
Exactly. And then second, there's the objective inability to stay still.
Yeah.
You'll see them constantly tapping, pacing, rocking, or just constantly shifting their weight in the chair.
And see, a new PMHNP hears that language, that distress, the sheer inability to settle down, and it just gets filtered through their brain as anxiety.
Right. Especially if the patient already has a comorbid anxiety disorder.
What's fascinating here is the structural nature of this mistake. It's built into the very fabric of how psychiatry operates.
It really is. Because we prescribe antipsychotics for conditions where agitation is often a core symptom of the illness itself. Severe bipolar mania, schizophrenia agitation is just part of the territory.
So when a patient on a new dopamine blocker suddenly reports more restlessness, the clinical reflex points the finger directly back at the underlying illness.
Precisely. The provider just assumes the disease is flaring up. The drug itself gets a total free pass.
Okay, let's unpack this with an analogy because I think this is crucial. Treating akathisia by raising the antipsychotic dose is like trying to put out a grease fire with water.
Oh, that's a perfect way to describe it.
Right, you're using the standard, universally accepted tool for putting out fires. But because you misidentified the specific type of fire you were looking at, your reflex causes a massive explosion.
You're pouring water on boiling oil.
Exactly. But I want to dig into the physiology here for a second. Why does a dopamine blocker cause this specific type of inner restlessness? Like, what's the actual mechanism driving that distress?
Well, think of the brain's motor system like a car engine. Dopamine acts as the transmission, putting the car into gear so the neurological energy can be released as smooth, purposeful movement.
Okay, so dopamine is the transmission. Got it.
Right. So when you introduce a heavy dopamine blocker like an antipsychotic, you're essentially shifting that transmission into neutral. But the engine, the raw neurological drive to move, is still running.
Ah, so the brain detects the blockade and sometimes even steps on the gas to compensate.
Exactly. So you have this roaring engine, a gas pedal smashed to the floor, but the car is stuck in neutral.
That vibrating, screaming tension inside the engine block, that is the visceral reality of akathisia, an internal revving that has nowhere to go.
And that makes the sheer panic patients describe make so much more sense, doesn't it?
It totally does. And our sources highlight a crucial piece of advice for spotting this from Lindsay Hill, the founder of the Psych NP Fellowship.
Yeah, she notes that akathisia ruins more antipsychotic trials than weight gain. Weight gain is the side effect everyone warns you about, but akathisia is the silent trial killer.
And her primary intervention for this doesn't even involve a prescription pad. It's all about the language you use during the interview.
Right. She says you have to eliminate the standard question, are you anxious?
And replace it with a much more specific mechanical question. Are you moving more than you want to?
Yes. Are you moving more than you want to? It completely sidesteps the emotional filter.
It forces the patient away from trying to describe an abstract emotional state and grounds them in their physical, motor reality.
It separates the psychological anxiety from the physiological revving of that engine. It's a total paradigm shift.
So changing the question gets us on the right track during the interview. But a suspicion isn't enough to justify altering a delicate antipsychotic regimen for a patient with severe mental illness.
No, definitely not. You can't just guess its severity. You need objective data before you start pulling levers, which leads us to quantifying the restlessness.
And the absolute gold standard for gathering that proof is the Barnes Akathisia rating scale, right? The bars.
Universally known as the bars, yes. It breaks the presentation down into 4 specific items.
Okay, walk me through those items.
Well, you measure the objective movement you can physically see, the patient's subjective awareness of their restlessness, and their subjective distress about that restlessness.
And each of those first 3 items is scored from 0 to 3, right?
Correct. Then you assign a global clinical rating that ranges from 0 to 5. The total subjective plus objective score ranges from 0 to 9.
Okay, I'm looking at this 4-minute observation protocol in the bars, and I have to be honest, it feels entirely detached from the reality of a busy clinic.
I know, raises an important question about practicality.
Like, if I have a 15-minute med check scheduled and a crowded waiting room, how am I supposed to just sit and stare to get an accurate read? We know patients mask these side effects.
They do mask them. They're often terrified we'll think their psychosis is worsening and send them back to the hospital.
Right. So a quick glance while I'm pulling up their chart is going to miss a patient who is actively using every ounce of their willpower to sit perfectly still out of sheer embarrassment.
And that time pressure is the exact reason the protocol is so rigid. You cannot outmask your own neurology for very long when the internal pressure is that high.
So if you just look at them for 30 seconds while exchanging pleasantries, they can hide it.
Exactly. They're using all their executive function to hold that engine still. But as the minutes tick by, the executive control slips.
Okay, so what is the actual strict protocol to defeat that masking?
The protocol requires you to observe the patient seated for 2 full minutes, and then observe them standing for 2 full minutes before you write down a single score.
Wow, 4 full minutes of just observing.
Yeah, because by minute 3 or 4, the true motor-driven restlessness inevitably breaches the surface. The foot starts tapping, the weight shifts, the pacing begins.
So the 4-minute window is a non-negotiable stress test for the masking behavior. I love that.
It really is.
Okay, so once we let the mask slip and get our score, what are the actionable thresholds for the listener? When do these guidelines mandate an intervention?
The thresholds are very cleanly defined. A global clinical score of 2 or higher requires treatment.
And if it hits a 3?
If that global score hits 3 or higher, you are looking at moderate to severe akathisia. That requires same-week intervention. You do not tell that patient to come back in a month.
And how often should PMHNPs be running this BARS test?
They should document a BARS at antipsychotic initiation, at every single dose change, and at every follow-up for the first 3 months of treatment. Then every 6 months for stable patients.
Okay, let's put this into practice. We have a patient. We did the 4-minute observation. They scored a 3 on the BARS. We have to intervene this week. What is step 1 of the 2026 game plan?
Step 1 is treating the cause, not the symptom. Before you even think about adding another pill to the mix, you have to look at the offending antipsychotic.
Right. Can the dose be reduced? Can the drug be switched to a lower risk agent?
Exactly. If you have a patient on aripiprazole, 30 milligrams for depression augmentation, dropping that dose down to 5 milligrams might resolve the akathisia entirely.
Which saves the patient from a whole new set of side effects from an adjunct medication. We have to know the risk profiles of the tools we're using.
Definitely. The guidelines divide these up pretty clearly based on how heavily they blockade those dopamine receptors.
Okay, so what are the high-risk culprits?
They are notorious for a reason. Aripiprazole, haloperidol, lurasidone, and generally the high-potency first-generation agents. They sit at the top because of their high D2 receptor occupancy.
And the lower-risk alternatives.
Your lower-risk options include quetiapine, olanzapine, and clozapine. Switching from a high-risk to a low-risk agent often releases enough of the dopamine blockade to quiet the akathisia.
There is a surprisingly practical detail in the sources regarding lurasidone specifically.
Oh, yes, the food absorption trick.
Yeah. The guidelines note that sometimes lurasidone-induced akathisia improves simply by ensuring the patient is taking it with food as directed and at consistent times.
You might not even need to change the prescription. You just have to fix the administration habits to smooth out the absorption.
That's such a great tip. But let's assume the worst case scenario. The patient's psychosis is barely held together. We cannot lower the antipsychotic dose without risking a severe relapse.
Right, so we have to use an adjunct.
My preceptors always taught me to reach straight for propranolol. I assume a beta blocker is still the unquestioned gold standard in these 2026 guidelines.
Well, here's where it gets really interesting. That is where the new data threw the field a massive curveball.
Wait, really? It's not propranolol?
Propranolol remains a fantastic option, but based on a massive 2023 network meta-analysis of 15 randomized trials, it is no longer the reigning champion.
No way. So what is?
Mirtazapine actually took the #1 spot for overall effect size.
Mirtazapine, the antidepressant.
Yep. It beat out propranolol, vitamin B6, trazodone, and biparidine in head-to-head comparisons.
How does a medication we typically use for sleep and depression fix a severe dopamine-induced movement disorder? What is the actual mechanism there?
It acts as a 5-HT2A antagonist. To visualize why that matters, think of dopamine and serotonin as sitting on opposite ends of a seesaw in the brain's movement centers.
Okay, the seesaw analogy.
Right. So the antipsychotic blocked the dopamine, slamming that side of the seesaw into the dirt. That violent imbalance is what triggers the akathisia.
Ah, and mirtazapine comes in and blocks the serotonin receptors on the other end of the board.
Exactly. It essentially removes weight from the high side, balancing the seesaw back out and restoring harmony to the motor pathways.
That makes so much sense. The dosing for this is incredibly specific, though. The guidelines hammer home that we are aiming for exactly 15 milligrams of mirtazapine at bedtime.
Yes, 15 milligrams is the sweet spot. It usually takes about 3 to 7 days to show its full effect on the restlessness.
With the added benefit of helping these highly distressed patients get some sleep and recover their appetite. But there is a crucial warning here.
A huge trap, actually.
Right. Doses above 30 milligrams can paradoxically worsen the akathisia.
It is a very narrow therapeutic window for this off-label use.
Yeah.
You cannot treat it like depression and just keep pushing the dose up, hoping for a better response.
You will actively pour gasoline on the fire.
Exactly.
Let's talk about the runner-up then, propranolol. If mirtazapine is out, we fall back to the beta blocker. But with propranolol, you are basically buying speed and trading it for intense babysitting.
Speed is definitely its primary advantage. You'll often see significant relief within 24 to 48 hours.
And the dosing starts at 10 to 30 milligrams 3 times daily, right?
Yes. But you hit the nail on the head regarding the babysitting. You are chaining yourself and the patient to a blood pressure cuff.
Because it's a non-selective beta blocker, so it's dampening the cardiovascular system along with the neurological restlessness.
Right. You have to check the resting heart rate before every single dose increase. If that heart rate dips below 55 beats per minute or the systolic blood pressure drops under 100, you have to hit the brakes and hold the medication.
And it is strictly contraindicated in patients with asthma, bradycardia, or hypotension. You cannot risk throwing someone into an asthma exacerbation just to stop their pacing.
No, definitely not worth the risk.
So what happens when you hit a wall? Like the patient has severe asthma, so propranolol is out, and you don't have access to mirtazapine. What's the next move?
We look to the dark horse of the 2026 guidelines, vitamin B6 or pyridoxine.
Vitamin, like an over-the-counter supplement.
It is, but it carries serious clinical weight. The dosing is massive compared to standard supplementation, though.
Yeah, the sources point to 1,200 milligrams per day. How is a vitamin competing with heavy-duty psychiatric drugs?
While the exact mechanism is still being mapped, B6 acts as a critical cofactor in the synthesis of multiple neurotransmitters. Flooding the system with it seems to buffer the harsh dopamine blockade.
So it has a slower onset, but the massive advantage is its safety profile.
Exactly. It has almost zero contraindications and far fewer drug interactions. It's highly effective for pure akathisia.
I want to focus on that phrase you just used, pure akathisia.
Yeah.
We have to talk about the elephant in the room.
The benztropine reflex.
Yes. The second most common mistake clinicians make, right after mistaking it for anxiety, is reaching reflexively for benztropine, Cogentin.
It is muscle memory for decades of practitioners. They see a movement disorder caused by an antipsychotic, and they immediately write a script for it.
But the new guidelines are actively dismantling the benztropine myth. It has a deeply ingrained tradition, but the controlled data shows very weak evidence for treating pure akathisia.
Weak is putting it nicely. It comes down to neuroanatomy. Benztropine is an anticholinergic. It works primarily in the nigrostriatal pathway, the brain's raw motor execution center.
So if a dopamine blockade hits that pathway hard, the patient develops Parkinsonism, tremors, stiffness.
Right, and benztropine smooths that motor execution out beautifully. But akathisia isn't just a motor execution problem, it's heavily rooted in the mesocortical and mesolimbic pathways, the areas governing emotion, reward, and inner drive.
So benztropine doesn't effectively penetrate that inner emotional distress. It might stop a visible tremor, but it leaves the patient feeling like their engine is still redlining on the inside.
Exactly, and it's not a harmless failure either. Adding benztropine unnecessarily massively increases the patient's anticholinergic load.
Which means constipation, cognitive blunting, and it actually raises their long-term risk of developing tardive dyskinesia. So what's the rule here?
The absolute rule from the decision tree is this. You only reserve benztropine for complex cases where the patient has mixed Parkinsonism plus akathisia.
Got it. Now, what about the alternatives? The guidelines briefly mention clonazepam.
Dosed at zero point 0.5 to 1 milligram at bedtime.
Mm-hmm.
But the sources are incredibly strict about its role. It is a short-term bridge, not a destination.
Due to the risks of physiological dependence and falls in elderly populations, right?
Yes. It should only be used to get a patient through an acute crisis while waiting for something like mirtazapine to kick in. Oh, and we also need to explicitly note the newer movement disorder drugs.
Like valbenazine and deutetrabenazine.
Exactly. They are FDA approved specifically for tardive dyskinesia. They are not approved for acute akathisia and should never be used as a first-line treatment here.
Okay, so let's assume we picked the right drug. We started mirtazapine, or we got them on a safe dose of propranolol. Prescribing the right agent is only half the battle.
Managing the timeline is where clinicians either secure the win or completely lose the patient. The third major trap is stopping treatment prematurely.
Because acute akathisia is stubborn, right?
Very. It can persist for weeks, even after you've successfully dose-reduced the offending antipsychotic.
The sources outline a classic pitfall here. A patient gets almost immediate relief from propranolol, the clinician thinks the fire is out, and they stop the beta blocker 5 days later.
And the patient immediately relapses right back into severe distress because the neurological imbalance hasn't actually resolved yet.
So what's the rule for the listener? How long do we treat?
Plan a minimum 4-week course of your chosen therapeutic dose. Once you hit that 1-month mark, you can attempt to slowly taper it over 1 to 2 weeks while monitoring their BARS score.
You also have to run a reassessment loop every 4 to 6 weeks on the underlying psychiatric indication.
Right. And if the akathisia persists, despite optimized adjuncts, you must switch to a lower affinity agent, even if the primary psychiatric symptoms are perfectly controlled.
Before we wrap up, there is a fascinating curveball hidden in the FAQs of our source document. We've spent this entire time talking about antipsychotics, but standard antidepressants, SSRIs, can trigger this too.
Yes, SSRI-induced akathisia is a well-documented phenomenon. Flooding the brain with serotonin can occasionally trigger that same internal revving.
Especially in the first 2 weeks of starting a brand new SSRI or after a dose increase. But the treatment hierarchy is identical, right?
Identical. Propranolol, mirtazapine, or B6. But the major difference is that simply reducing the dose of the SSRI usually resolves the issue entirely without needing a secondary drug.
Which circles perfectly back to step 1, treat the cause before you treat the symptom. So let's synthesize the absolute core takeaways for you, the listener, navigating this 2026 update.
First, never treat akathisia like generalized anxiety and score everyone with the bars.
Try to reduce or switch the drug first. Rely on mirtazapine, propranolol, or B6 instead of reflexively grabbing benztropine. And treat for at least 4 weeks.
So what does this all mean for you? If you only change one thing about your practice after today, swap the question, are you anxious, to, are you moving more than you want to?
That one question will save a third of missed cases. Now, I want to leave you with one final lingering question based on these sources.
Okay, let's hear it.
We've focused entirely on acute akathisia today, which happens within hours to weeks, but the source material briefly mentions tardive akathisia, noting it emerges after months or years and behaves differently.
That's a great point to bring up.
If the standard algorithms we just discussed are for acute chases quieting an engine just unexpectedly thrown into neutral, how radically different does the playbook have to be when the akathisia doesn't show up until 6 months later? That's something to keep in the back of your mind as you monitor your long-term patients.